our various speakers has taken us through the whole process, range from screening, pharmacological management, of course the psychosocial aspect of management, and of course we talk about the ethical aspects of things as well. So if you actually look at it, so as a primary care physician, so you'll be looking at, okay, so how am I going to package this nicely and apply it in our clinics on a day-to-day basis. Of course, now before I comment, of course the main thing is if you think, well, especially for those who work in the polyclinics, you can do all this in 5 minutes, then I tell you, forget it, it will not work. So bottom line is, as what has been mentioned by previous speakers, patient needs our time. The caregiver, they need our time as well. So we have to give them the time. So we really have to find time of how to sort of conduct a very effective consultation and maybe provide provision of care. I mean, it probably sounds very idealistic, but I guess somewhere we have to find a balance of how to deliver it, knowing that our population is going to age, and sooner or later you're going to have patients with dementia coming to you, like it or not, right? So you have to be prepared. Anyway, that's why you're here. Okay, so the contents on the menu will have all this, basically running through, okay? Of course, giving some primary care aspects of things. The screening of dementia, how we co-manage. I use the word co-manage, why? Because at the end of the day, you're not alone. You're not the sole player in managing this patient. So with you still have your specialist. Even though the specialist may have so-called discharged the patient to you, I'm quite sure our specialist colleagues are ever willing to provide a consult. You know, you give them a call, they'll tell you or advise you how you want to manage this patient. And of course, it's not just specialists yourself, you also have your OT, your PT, and of course your community services as well. They play a very big part in how we manage our patients in the community. Right? Now, of course, don't forget our caregiver management, of course, decision making and driving, which JJ has mentioned. To start with screening now, who do you screen? So if you actually look at your guidelines, there are situations where you want to conduct a screening. Of course, we do not want to do a screening for all elderlies, but certain categories of patient that comes to you, you might want to screen them. So of course, first and foremost, a patient will actually complain to you. They are showing signs of progressive cognitive impairment. Yes, this is one group that you want to screen, or the caregivers or the family members highlight to you that this is happening to your family members. And of course, in the process of normal consult, your usual history taking, you may sense that something is wrong, I mean, in terms of the cognitive aspect of this patient, then again, you might want to move on to screen this patient as well, right? And of course, those with increased risk, strong family history coming to you very worried, then I guess it's justifiable that you will have to screen them as well, right? And of course, there will be a point in time where elderly patients coming to you who say that they may need to make important decisions, where this mental competency is in question or it becomes a very important thing. Again, you might want to do screening. So the next thing is, how do you screen? Of course, if you actually look at the guidelines, there are many ways. There's subjective approach and objective approach. Then of course, one of which is your DSM-4 criteria for dementia. Right? You have your memory impairment, plus deficit in one other cognitive domains of sufficient severity to cause perceptible impairment in social and occupational functioning. Of course, you look at the annex here, you'll find the guidelines there. Then of course, I'll bring to you, okay, what is can be done easily delivered in a primary care setting will be your abbreviated mental test and your ECAT. These are actually 10 questions, sort of screening tests, okay, 10 points each, right? And then that's where you can score them accordingly. Easy to deliver, right? Of course, as compared to your MMSC, of course, you got a Chinese version and of course the Singapore version, all that. That one you can still deliver, but personally I find it's quite time consuming actually. So it all depends. Seriously, if you really have time in your office and you want to deliver the MMSC, really, by all means, you're not AMT or at least ECAT, you can use it. Right. Then of course you have your IQ code and your neuropsychological testing, which usually I don't think we will do in our setting because it's very time consuming, and for neuropsychological testing usually also done by a neuropsychologist, not by us, or at least for primary care. So having used some of those tools, then the next thing is of course you want to do a physical examination, because why you want to look for possible reversible or secondary causes. So neurological examination is one important aspect. And of course, a mental state examination as well, because you also look at whether there are other contributing factors like depression that might contribute to the symptoms. Now, of course, very important aspects, of course, we want to do a functional assessment as well, because in elderly, it's not just disease, but functional aspects as well. So take things like IADL and instrumental activity of daily living, basics activity of daily living as well, right? The IADL, BADL, you have to assess that as well as an overall holistic management, right? Of course, certain tests we can consider doing because it probably can be done. I don't know how much you'll charge in a GP setting, right? But probably can do it. So things like FBC, urea electrolytes, thyroid function tests, serum calcium, B12 levels, blood glucose levels and what have you, as mentioned in the guidelines, right? This is probably doable. Then, of course, there's this issue about neuroimaging, structure versus functional imaging. Of course, the main thing is want to identify, again, reversible or some important surgical brain lesions, right? So you're looking at cerebral infarcts or some tumor stuff. Then, of course, again, you look at the guidebooks, there's some criteria that you can want to use for reference in whether you want to decide to send a patient for scanning. That's the CCCAD. That's your Canadian Conference Consensus on the Assessment of Dementia, right? Read it. Quite a number of things. It basically look at whether, in short of it, whether it's an early onset, whether it's a very fast onset, whether there's any focal neurological deficit that's detected, amongst other things. Now, coming to co-management. So that much we have, that's up to all the screening I mentioned. So now we actually look at how we co-manage. Like I said, when we say co-manage, it means we want to manage as a team. Everybody gets involved, right? And it's holistic. So of course, we look at pharmacological management. I think previous speaker has mentioned about the types of medications that you want to use, range from your acetylcholine esterase inhibitors and your memantine. Okay, so what we can do when patients come to you, a lot of times usually they would have been started by the specialist anyway. So like I said, probably the follow-up period will be like 4 months or 6 months. So in between they'll come to you for whatever reasons. Right? So sometime along the way they may come to you and they may present with adverse drug reactions. So that's what you want to look out for as well. Right? So things like, has been mentioned earlier, the GI side effects, tremors, or even CNS symptoms, these are something you want to look out for. Right? So of course, if you find that there are problems arising or ADR arising out of the treatment, again, pick up a phone, speak to the specialist, the principal specialist, discuss, see how you want to manage. Is it wise to tail down or to substitute for other medications? It's good to consult with our specialist colleagues on this aspect. Then of course, titration and recommended dosing. Again, something that you might want to consider, again, in consultation with the principal specialist as well. Of course, if you're very confident, well, by all means. Then, of course, at the end of the day, there's always this early referral back to the specialist. If you really find that this patient is really deteriorating faster than what is anticipated, then you think that something else is really not right and needs urgent attention, then it's good to actually refer back to the principal specialist rather than wait for 4 months or 6 months down the road for the appointment. And of course, that's for the medical aspects of things. Of course, then to talk about the behavioral aspect as well. Well, actually look at this one. This is the slide. Actually, it's not actually Chinese, it's actually Japanese. All right? The Chinese are quite 老人痴呆症, but if you look at the one, the Japanese is quite 认知症. But the important thing is to look at the BPSD. It's actually highlighted all the things, well, in kanji, which also spelled out all the things of BPSD, actually. All right, you managed to find this slide in Yahoo. Okay, so basically, again, what you want to do? Again, you want to identify, okay, important thing is, of course, if there's a patient presenting with a lot of psychological symptoms, first and foremost, you want to identify whether there are any possible triggers. Because sometimes these so-called psychological symptoms can arise because of pain, infection, or what have you. So you may actually want to find out whether the patient has underlying all this, which are, once you treat it, it may potentially reverse the symptoms. Then, of course, as we also mentioned, talk about NPT, the non-pharmacological therapies, right? So all the things that's been mentioned about medical, nursing intervention, music therapy, what have we, and of course psychological therapies or environmental modifications as well. But a lot of time that part, of course we alone sitting in your clinic, you can't really do it, but bear that in mind. With that, you can actually rope in the community resources to help you in this aspect. Then of course the pharmacological interventions when it comes to treating this BPSD, things like antidepressants as you mentioned, and of course antipsychotics. But of course there's a caution, and also highlighted in the book, is patients with DLB, dementia with Lewy bodies, be careful with these antipsychotics. Right? Then whatever you do, you want to start medicine, yes, go ahead, but please monitor for possible underlying adverse drug reactions, right? Associated with the specific items that you want to treat or you want to start treatment with, right? Then again, being the primary care physician, if you do find that patient is still deteriorating despite what you've done, again, early referral back to a specialist or principal specialist would be useful in this aspect. Okay, of course, like reduction of vascular risk factors. Of course, we actually look at the book. It says that there are observational data to support it. Of course, there's no real RCT to support this. But having said that, as a primary care physician and knowing that our elderly do have dementia, hypertension, and hyperlipidemia, that's why I call it DHL, you still want to manage them anyways. Optimal management, optimal control, right? So this is part and parcel of our daily management of our patients with chronic disease, right? So that goes without saying. And smoke cessation, if patients still actively smoking, please tell them to stop smoking. And of course, the use of antiplatelets agents and anticoagulants where applicable. And very importantly, utilizing of community support services. In this aspect, you probably look at two areas. One is, of course, the general elder care service. General elder care service, of course, we look at HNF, home medical services, example Code 4, Huamei, right? And of course, maybe some daycare centers as well. Of course, that's for the general. And of course, on top of that, you have your befrienders, Meals on Wheels. These are the usual general. But the rest, of course, you also have specific ones. So you can gather information on how to refer to all these specific dementia services. Will be things like dementia daycare centers, right? And of course, the nursing homes with dementia facilities as well. Because all these can provide environment or specially trained staff to actually manage your patients better. Now, like I said, caregiver is very important because many of our patients are actually managed at home. So you do not take care of a caregiver. The moment the caregiver gives up on the patient, the whole system, the whole care system will collapse, right, in the home. And of course, there may even be this possibility of elder abuse coming in because the frustrated caregiver will vent the anger, will physically abuse the patient. We do not want that to happen, right? So we must take care of caregivers. So again, community resources is something that I want to tap into. As example will be respite care, because caregivers need a break, right? They may want to go for a short trip. Encourage them, then maybe find a suitable temporary placement for the patient in one of those homes for it, right? And of course, psychosocial support, and of course, training, because even for us in the medical field, be it nurses, be it doctors, we may not have an overall good knowledge complete knowledge of how to manage dementia patients. So we still want to send these people, be trained, to give them, equip them the knowledge, right, so that they can better cope with the patients and how to care for them, right? Okay, this decision making and driving, I think probably not very unfamiliar. For those of us who actually done taxi driver vocational license for elderly taxi driver vocational license, there is a component where you have to do AMT, I think, for those who have done it. And also there's one component that you have to refer to the occupational therapist, where that applicant will have to be subjected to this driving test. So actually, the life of that occupational therapist can be very challenging. Okay, so basically, the drive. Okay, but importantly, now driving itself, if you actually look at your ADL, it forms one of your IADL, right? In terms of being able to take transport, be it driving or taking public transport. Now, so it is a big thing for many of us. Us as in eventually when you grow old. Okay, because it represents independence, freedom and mobility. So imagine if you were to declare a passive sentence to this patient that thou shalt not drive anymore, then we have a very lot of severe psychological impact on the patient. Actually, that means to that person immediately means, oh, I'm useless, I'm no longer useful, or incapable of doing things. So that aspect, you have to manage it carefully and not just pass a sentence, okay, you cannot drive, but you have to explain, right? Like what JJ has explained. No, you have to actually talk to the patient, even talk to family members and all that. Because ultimately, you have to balance between this individual freedom and patient confidentiality and the public and patient safety. That part has to come in, right? Because if you find the patient seriously cannot manage the wheels, then I mean, in the interest of public safety, I think it's better that this patient don't drive. For all you know, there'll be this day that this person is driving and you're the one crossing the road. So he'll be driving his car towards you, right? So it's things like that you really have to take note of, right? So of course, if you really find that patient request and you think that there's still an element that patient might be able to drive, then of course you want to refer for proper assessment. So OT and all that, you have to refer them. But I understand that apparently Singapore currently there's only one hospital that has it, and that's Tan Tock Seng. Occupational therapist. I think the department is quite small. I think there are maybe 2 of them doing it. So you can imagine the queue can be quite long. Time can be quite long. Now that's for driving. Now what about decision making? Again, declaring someone dementia doesn't mean that patient will lose that capability of making decision, like what our previous speaker has mentioned. So, but having said that, there will come to a point in time that either the family members or the patient will come to you that they need to sell the house, or they need to do some transfer of assets or whatever. Now that part, because it also involves legal matters, and if you really find that you're not comfortable in saying that, okay, I can declare you competent to make that decision, I think it's still better to refer back to the principal specialist to make the assessment and then give that specialist input, whether a patient is capable or competent enough. Right, just before I move on, or rather end this slide, just one thing, when it comes to the psychological management of patients, if patient is truly violent, okay, that you think is not capable, that it's not safe to actually manage a patient as outpatient, then you better send the patient to the hospital, be admitted. Of course, in this case, you can consider sending the patient to IMH, to the admission ward itself, where patient may have to be admitted and be stabilized. Now, with that, I thank you.